Hello and welcome to a fairly dark edition of From Belly to Baby. It actually is not dark, it's a really fun episode. We're talking ultrasound this week and we have a couple of great helpers with us. I feel like I'm posing for a bit of a family picture right now, but we'll get to moving around in a little bit as we explain what we're doing. But right here we have Dr. George McCombs. He's the chairman of OBGYN for Barnes-Jewish, Washington University, the whole kit and caboodle?
Both, yep.
All right, and you're also a maternal fetal medicine physician.
I am, yes.
So can you tell us a little bit about what all of those words and titles mean and what you do?
Sure, well, I run the whole OBGYN department here and at Barnes, so that's a great job. My clinical job is I take care of women with high-risk pregnancies. And maternal fetal medicine docs are people who have extra training. So we spend an extra 3 years after our 4-year residency in OBGYN, learning how to do prenatal ultrasound like this, and learning how to take care of sick moms. So it's a great job.
All right, and we'll get into a little bit more detail in just a second, but Kim is to my right, and Kim, you're going to be doing the dirty work. At least you're the one who takes all, actually it's not dirty work, it's the really fun work. You get to take all the great pictures. You are a photographer by trade.
That's right.
So you are one of the lead sonographers here. Tell us a little bit about what that means, what you do on a daily basis.
Well, we get to scan babies all day long. I do high-risk ultrasound, and we do a detailed ultrasound. We can do it in the first trimester, second trimester, and third trimester, and we get to see babies all day.
All right, and so everyone knows that this 20-week ultrasound is a big deal, that it's an anticipated moment in every pregnancy, and a lot of people look at it as the gender reveal ultrasound, but in this case today we're going to do a pretty thorough but slightly abbreviated version. We're leaving everything, we're taking everything into consideration, but we're leaving gender out. My husband and I are actually not going to learn gender until delivery day. So if you happen to see anything, I'm going to issue this disclaimer now. Please don't put anything in the comments. Just keep it to yourself and know you know a secret. But as we are going along, we'll be talking about what measurements you take, because this is, more importantly, it's not about gender, it's about a lot of other details. So what are you all looking for as you scan a mom at 20 weeks?
Yeah, so we certainly do like to tell people that sort of news if they're interested in knowing the gender and getting some good pictures that you can start a photo album for. But from a medical perspective, we're really focused on making sure that we don't see any signs of any birth defects in any of the organ systems that we're able to see. And that can be important for planning and being ready for things after delivery. So that's our major focus, is making sure that everything looks good. We don't see any signs of any problems, and the baby looks as healthy as it can.
Okay, terrific. And I should say Laura is working the camera today, and if you see the ceiling a couple of times, it's not because she's dropped the phone. Obviously they're doing a real scan here, so there will be moments when she tilts up for privacy purposes, and also Kim has agreed to very graciously announce if there are any danger zones that she's getting to as far as revealing gender goes. So we are going to avoid any of those images. Just take a look at the ceiling for a couple of seconds, enjoy some music in your head, and we'll come right back. We'll keep talking through it. But we'll go ahead and get set up and keep chatting a little bit about, I know Dr. McCombs, we were talking about how this is not my actual 20-week ultrasound, full disclosure. I had that last week. So when I went in, it was a maternal fetal medicine fellow who was taking the initial pictures. There was a sonographer there as well. But it was in a facility that was designed specifically for ultrasound. Is that where everyone is going to get scanned, the type of thing that's going to happen to everybody?
Yeah, so if you're at one of our practices, that'll happen. I think there are some places where general OBGYNs do some of these ultrasounds, and I think probably for this particular kind of ultrasound where we're looking at anatomy, I think patients should want to have the most highly trained people both getting those images, like Kim, who's one of our absolute best, although she's nervous. And
we told her you're all safe. Don't worry.
Yeah, and having a high-risk person look at it, because we do this all the time, every day. We don't really do anything else. This is really our job is to do this. So again, I would really encourage people to think about, at least for this ultrasound, the really important one, going to a high-risk doc.
And is that something you ask your own physician to refer you toward, or is it an automatic?
It depends on the physician, but I think asking is a good idea. At least again for this 20-week ultrasound. All the other ultrasounds aren't quite as important when we're just sort of doing measurements of growth, but when we're looking at the heart and the kidneys and everything else, I think you really want to have a skilled person doing it.
All right, terrific. Well, Kim, we'll go ahead and
All right, let's get
lay back. And I
started.
know when I was in mine, it's more than 10 fingers. Everybody says 10 fingers, 10 toes. But as we'll learn as you're going through everything, you're looking at a lot more detail than
Yeah.
just that. You
Yeah.
want to know that there are 2 hemispheres and 4 chambers, first of all. But are there other things that you are particularly inclined to start with and to look for?
Usually we start with just some general measurements so we can estimate the size of the baby.
Mm-hmm.
So we actually estimate in pounds and ounces.
Mm-hmm.
Probably for you it's going to be in ounces.
Yes, I
Since
believe
they're-
it was
since they're
ounces
early.
last week, unless that kid has grown a lot. And there's been some pizza involved in the last couple of weeks. I won't
Yeah.
lie.
Well, that pizza takes a while to kick in. So we usually start with measurements, and then once those are done, we start to dig into different parts of the baby's anatomy, which we'll be seeing in just a little bit.
All right, and what are we looking at first of all? Let either one of you chime in. Of course, it looks just like
So
a.
the first picture I usually get is of the cervix. So we can see your cervix right here.
I'm going to ask you. I do not know what audio quality is like, but if you could speak up because you're facing
Yep.
this way, my
Okay.
guess is it bounces.
And here's your bladder.
Mm-hmm.
And next we look at the placenta. The placenta is on the front wall of your uterus, not covering your cervix,
Mm-hmm.
which is right here. So that's
And why
okay.
is that important to note?
Well, if the cervix is covering, I'm sorry, if the placenta is covering the cervix, we worry about something called placenta previa.
Mm-hmm.
And that's how it's defined, is just the placenta covering the cervix. It can be a problem if it remains that way because you can have bleeding and the baby can't come through the cervix.
Okay.
So it's something important for us to look at.
All right.
And you're in good shape.
Terrific.
Yeah,
Thank you.
You're previa free.
And I should also note that if anyone has any questions regarding ultrasound in general or questions about high-risk fetal medicine, you're welcome to write those in the comments, and we have some folks back here who are going to relay those to us.
Okay, so we're looking at the head right now. You can see the skull. On ultrasound, bone shows up bright white. You guys can all see the skull there. And fluid shows up black, so here's the amniotic fluid right over here, right here. So the first picture I'm going to get is of the head.
You know, one of the interesting things about the bones is as babies get further along, the bones get thicker, so it actually becomes harder to see things that are inside the baby.
Oh, interesting.
Yeah, so if you do an ultrasound, like now is a great time to look at all the anatomy, but looking at 33 or 34 weeks, it's really tough because the bones are really calcified and you just can't, the ultrasound can't go through those as well.
And I guess that makes sense that as baby grows, he develops and everything becomes more solid. And is there anything that leads into the question of, I guess that's the magic point about 20. It's not that it's halfway, but it's that you can see enough, but it's not fully formed that you can see
Exactly.
much.
It's really the ideal time to look.
And we're looking at, this was my big question whenever they were doing my scan, are those 2 hemispheres I'm seeing. So I see a line down the middle.
Here's the phalanx, that's in the middle of the brain. You can see on each side right here. Here's the lateral ventricles right here.
Yeah, so why don't we freeze that, Kim?
Yep.
And can you point to the lateral ventricles? Yeah, so the ventricles are, one of the reservoirs for where cerebrospinal fluid stays. We all have fluid that sort of circulates around our head and into our spine. And it's important for us to see these ventricles because if they're very big, it might suggest that there's a blockage in the system that handles that fluid. So it's one of the things that we always look at on ultrasound.
And as you're looking at this, and we'll talk a little bit more later, but if you see anything that isn't what you want to see exactly or that causes you concern, is this a point at which you can do anything about it? With some issues, I mean, are there other doctors that you can talk to, places you can refer women at this point for corrective or further testing?
It really depends on what the problem is. There are some things that are amenable to treatment while the baby's inside. Most things, though, you can't really do that. But it doesn't mean that you can't be ready for what's going to happen after delivery. So if we identify that the baby might have a blockage in those in that system, for example, talking to a pediatric neurosurgeon would be helpful. Because they're going to be the ones to help to fix things after delivery.
Next we can see the cerebellum.
Yeah, so it's that little dumbbell-shaped structure there, and the cerebellum. That's great. The cerebellum is in the back of the head. It's a very important structure in the brain. It really helps us with balance. So people who have cerebellar problems tend to be a little bit unsteady. And again, it's one of the structures we always look at the back of the head.
You can can see the spine
So
there.
that looks like a spine.
It's like a little railroad track. You can see that all the way down. Looks great. You can see like a skin line right now.
Yeah, so this is another really important area for us to look at. And we usually look at the spine both this way, sort of a longitudinal picture, but we also usually look at each level sort of in a cross section. So if maybe if we were looking in half, we can see a picture of that.
Just looking up right here, Doctor.
Yeah, so that's sort of a cross section. And we look at the spine for a couple of reasons. So sometimes we can pick up something like scoliosis in utero, where the spine is curved abnormally. The other thing that we look for, one of the things that actually is amenable to in utero treatment, is spina bifida.
Oh yeah.
Where there's an opening, essentially the bones haven't, the bones of the spine haven't come together, and there isn't skin covering that part, and that's spina bifida. That's again one of the important things that we look for.
There's the hands.
It was a face toucher previously, so.
There's the face.
There we go.
Beautiful.
You can see the lens of the eye right there.
Oh my gosh, that's so crazy. The level of detail that, I mean, it does look a little alien-esque, but knowing that you can see that measure of detail is extraordinary. And I see a little bit of a pulsating in
the heart.
It's my left side as I'm looking at it up here, and that's the heart.
That's the heart.
Okay.
Yeah, babies definitely look a little bit ghostly on these pictures, but that's totally normal.
See both hands are right in front of the face. You can see the radius and ulna on the forearm here. Baby's awake right now.
And I don't feel anything. We were talking about this. I feel some stuff like later at night if I'm laying down. I'll notice it if I'm paying close attention. But that's because you said of that first look you took of the placenta, that it's in a place that's not unusual.
Yeah, that's right.
Placenta's right here.
And if the placenta's on the outside, it's harder to feel.
It's on the front. So your placenta's on the front of the uterus, not on the back.
On the back, okay.
So it's a little bit harder to feel. You'll feel movement soon enough, I'm sure. So we look at the hands. We like to see the hands, like we count the fingers, make sure that there's 10, and we like to see the baby maybe do a little bit of opening and closing of the hands. And your baby's
Not really showing me that well.
this is an active baby. So it could be some
Baby's
sort of,
awake.
some sort of athlete.
Oh, well then it takes after its father because that is not me.
You can see the lip. Right here.
Sort of looking up,
Sure.
up under the chin, up at the nose and the lips. Yeah. That's a good view for us because we look for a cleft in the lip. So there's like a little.
You can see that at this
We
stage.
can see cleft lip and we can see cleft palate, and that's important for a lot of reasons. For sort of knowing that in advance of delivery, so it's an important thing for us to look at.
And I want to point out too, at this stage, there was a maternal fetal medicine fellow who was conducting my initial ultrasound, and it was sort of a disclaimer he gave at the beginning. I'm getting a lot of feedback from you as we're going along, but that isn't necessarily typical. That a lot of times it'll be, if you go through a scan and everything looks fine, then then you're good to go. And if there is anything concerning, you'll hear from someone afterwards.
Yeah, we don't usually talk a lot during the scans themselves, and certainly if we ever see something that we're worried about, we don't bring it up at that second because we want to make sure that we see everything else on the ultrasound, that we don't want to get distracted from making sure that everything else looks okay. So that discussion usually happens, after the ultrasound is finished. And you mentioned one of our fellows, at least initially did part of your ultrasound. Fellows, so everyone knows, fellows are people who finished their 4-year training in OB/GYN, and they could be in practice taking care of patients, but they've chosen to spend another 3 years focusing on high risk. So they're actually highly trained and highly skilled people. But besides a fellow, and we can't see it here, but we have a room that has all of the ultrasounds that are going on in the unit. So there's actually an attending physician there who's looking at all of those as they're going on and reviewing every single image. So if there ever was anything concerning on ultrasound, that would be the person who would come in and talk you through it and help you to understand what's happening.
Gotcha. All right.
Great.
This picture is a 4-chamber view of the heart. See the 2 ventricles?
Yeah, the ventricles are the chambers that really sort of pump blood out of the heart, and they are connected to the atria. And the heart's really important to look at because in terms of birth defects, heart defects are the most common.
Mhm.
So we really focus in on looking at the heart. In that great 4-chamber view that Kim had, that'd be a great place to look, for example, for a hole in the heart, which I'm sure everyone has heard of if there's sort of a connection between the 2 ventricles or the atrium. And then we look at some very, very specific things that are going to be hard to see, I think, for our viewers, about how the blood vessels come out of the heart, to make sure that they're going in the right direction, to make sure everything is connected normally as well. But there's some pretty sophisticated pictures.
Is it the blue and the red, or the green and the red that I would have seen? There was a contrasting color. Yeah.
Yeah, the blue and the red, this is called Doppler, and Doppler is really looking at flow. I think sort of you would think sort of intuitively that red would mean artery and blue would mean vein. It actually isn't like that.
Okay.
It's just the direction of the flow towards or away from the transducer. So, but it's just showing that there is flow, and that color is oftentimes helpful to look for a hole in the heart. You can actually see blood going across.
Gotcha.
Your baby rolled over, so I can't get
Yeah.
a picture of that.
And I didn't feel it. It's so weird.
You know, I think one important thing about that is probably about maybe 1 in 10 women will need to come back after this ultrasound if we couldn't see everything that we like to see.
Oh, interesting.
And that's oftentimes based on the position of the baby. So if your baby was turned over and the spine was sort of up, we'd have a very hard time like getting great images of the heart. So it's not uncommon at all, and I don't want you to be upset if we say we couldn't quite see the heart well enough. It doesn't mean that something was wrong. It just means technically like we couldn't see it because of the position or movement or something else.
All right, terrific. That's good to know. Anything that decreases fear is always nice to know.
Yeah, we try not to scare our patients to death.
And look at the renal arteries.
Yeah.
So this is, I'm sorry, say that again. It's
The renal artery, so we can see the blood flow here to each kidney.
Okay.
So here's the aorta. And the renal arteries going off on each side.
Yeah, we like to look at the kidneys because kidney abnormalities are also pretty common. The fluid around the baby is normal, so that lets us know that at least one of the kidneys is working well.
Mm-hmm.
But we do like to look at the kidneys. Can we get a cross section, Kim?
Of kidneys?
And are there things that you will discover at this appointment too that, and I'm thinking of someone in particular that I knew that I'm going to butcher whatever it was called. It was a leak of some sort that they detected with mom, and amniotic fluid leak. Does that sound possible?
Maybe.
Okay,
Like
I could be. I'm not medical. I just know the language well enough to be dangerous, because I know a little bit, but not enough to be well
We know you're
informed.
dangerous.
But there are things that you can identify at this that would indicate then bed rest or best treatment going forward for mom too.
Yeah, absolutely. One of the things we're not going to do today, I think for a lot of reasons, we also normally do an ultrasound to measure how long the cervix is.
Mm-hmm.
And that ultrasound is done with a different kind of ultrasound that's
Yes.
transvaginal.
Yes.
And that's important. That lets us know about the risk of early delivery.
Okay.
So if the cervix is very short on that, you're at an increased risk of early delivery. There's some treatments that we can institute to help to reduce that risk. Can you point out the kidneys? They look actually really good.
Here's kidneys, and here's the pelvis in each kidney.
Yeah, so this is a cross section. So again, if we were sort of like looking at baby sort of in half, and the spine is back. Can you point to the spine?
Right here, here's the spine.
Right, and then the front of the baby is up there, and then the kidneys are there's one on each side of the spine, and we look to make sure that there's no big cyst in the kidneys, or we don't see any signs of a blockage. We certainly don't see anything bad on this. Looks great.
Right. And I should also say I'm looking at a monitor up here, so I'm not just totally looking through them. There is a TV screen back there for me to watch.
And we can put the masters on that if anybody.
Oh, perfect. Yeah. That's great.
Oh, just a thought.
And here's the diaphragm, and there's the stomach. Here's the heart.
Yeah, so that's a great picture. So the diaphragm is important. The diaphragm separates what's in the chest from what's down below, and sometimes that could not develop normally. There's going to have to be a hole in the diaphragm where the things from down below come up into the chest, and that's really important to know about because that's is a pretty serious condition.
And we do see a lot of that's congenital diaphragmatic hernia,
That's
and
exactly
we
right.
see a lot of babies in our NICU who are immediately transferred there upon delivery for further treatment. And we've seen a lot of them do extraordinarily well.
Yeah, absolutely. So I think our place does a great job of babies with diaphragmatic hernia. And, you know, it's important to know that diagnosis, if you can, before delivery. Because a patient is always better off sort of delivering where the baby's going to be taken care of, rather than delivering 3 hours away and have the baby come in by helicopter or something like that. That's not ideal.
And it's interesting because right now we talk about the construction on Kings Highway a lot, being toward everybody's dealing with traffic for a good reason, but right now we're all on one campus. We have our maternal fetal medicine physicians, the obstetricians, we have the newborn medicine physicians, but coming in toward the end of the summer, you're all going to be very close together, connected just by a bridge. So is that something to even take into consideration, where mom will be in proximity to baby upon birth?
Absolutely, especially for our high-risk moms that we might, you know, expect a baby that's going to need some extra care in the neonatal intensive care unit. You know, in our new space that's opening in just a few months, be able to walk right across a little bridge right into the NICU. So it's going to be absolutely fantastic for patients and for families.
Yeah, it's really neat to tell people, if you're ever driving down Kings Highway, to look at that new bridge and to know that's all that would separate mom and the people who are caring for her from baby and the people who are caring for baby. All right, so we have now.
Now this is a cross section through the abdomen. So we measured the head, the belly, and the thigh bone, and here is the abdominal circumference.
And this is one of those key measurements that we do that helps us to estimate the size of the baby in ounces and pounds.
And Kim, are you taking measurements along the way typically whenever you're going through this? Okay.
Yes, so I measured the abdomen, and here's the stomach. That's
You're so good, we don't even know when you're doing it.
Kim is not normally this quiet.
And I guess we want to go to the femur now, measure the femur?
Yeah.
Okay, so maybe...
So turn the camera up for a second until we get, all right, oh, look at that ceiling. And we do know in my case, and they can still hear us, so this is, usually people know
Welcome
in
back.
ultrasound by this point whether or not they're having multiples, but I've known a few people who have gone into this thinking they were carrying one and walk out knowing they weren't having two, or two knowing they were carrying three at that point. So this is a point at which you definitively tell how many are in the house.
Yeah, I mean, if Kim doesn't count the right number of babies,
I'm in trouble.
Right, she's getting a new job. Yeah, no, but it's pretty uncommon to sort of like find out at 20 weeks that you're having twins or triplets, but it does happen every now and then.
And these are the people I reference who discovered that at their 20 weeks are generally people who have been, I mean, it was years and years ago. So technology has come an awfully long way since then.
I remember back in the days when I was training, we had a patient who was in labor and delivered her first baby, and her doctor said, "Oh my, it looks like you're having twins." And surprise, surprise, I'm not kidding. And I was like, "Oh my goodness gracious."
Not my fault. That's what I would say on that one.
I was not an attending physician.
One of the other measurements we do get is of the femur, so here's the femur.
Thigh bone. Another important bone that helps us to estimate the size of baby.
Okay, so that's interesting. I didn't realize that as they were going through what the importance of getting those measurements was, but it's knowing how big baby is. Does that all contribute to overall weight when you're giving an estimate at the end?
So the three things are the head, the abdominal circumference, and the femur, and then there's sort of mathematical formulas that are used to calculate or to estimate the actual size of the baby in pounds and ounces.
Must be a foot. Yep.
Look at that. You can see the little toes. You see the lower leg right there, both bones in the lower leg, and both feet look great.
Yep.
See both of them.
And feet are good to look at because we look for club feet, where a foot might be turned in or turned out. That usually doesn't have any implications for delivery, but is going to be important for afterwards. Those need to get fixed.
Okay. And there, are we back toward the face now?
That's the face.
All right. So are those all of the measurements you're taking along the way? Okay.
Yep. Should we check out the biometry?
Yeah, let's do that.
And biometry is?
All the measurement sites.
All right, terrific. So are you done with me here?
No, because we're going to do a 3D picture.
Oh, okay.
In a couple seconds, but we're just going to look at the numbers first. Is that okay, Abby?
Yeah, that's fine. I'll just say we'll.
I didn't measure the femur. I need to get more
Oh, no,
measurements.
okay.
I thought I measured it. Maybe I didn't take it.
I'm attempting to be somewhat modest, and I went to put my hands around here, and I'm
You
like,
got
oh
trouble
no,
over there.
I'm
Yeah.
covered now.
You're out there, yeah.
Yeah, we're gonna lean back up.
We're okay.
Yep, we're good.
Oh,
This baby's modest.
Excellent.
Mm-hmm.
such a gentleman or lady.
That's right. Polite is the order of the day.
The biometry looks good. Baby weighs 12 ounces now.
12 ounces. All right. Well, it's gained 2 since last week.
And what percent? I'm sorry.
I have gained more than 2
45th
ounces since last
percentile.
week.
Good. So when we look at the size of the baby, we come up with a percentile. So how big is your baby compared to all other babies born in the United States at this time in pregnancy? And you'd be happy to know you have a very average sized baby.
That is exactly what every woman wants to hear. I don't
Average.
want to hear there's a giant in there.
Average is good in this case.
All
Too
right.
small is not good, and sometimes too big is not good. Nice and average sized.
All right, and we'll go ahead and remind people they're welcome to shoot some questions, and if you have any, if not, totally fine as well. But we are going to get a 3D image here in a second, and this is not necessarily normal at this age, correct? Or at this stage?
We can sometimes, the farther along you are in the pregnancy, the better the picture's going to be because there's not a lot of fat on baby right now. So baby's moving around. You can see the arm in front of the face.
Babies like this.
Okay.
See the arm right there.
Oh, funny.
There's the upper lip. This is placenta right here, kind of.
Blocking us.
Say
Blocking
nice
us.
big pillow. And going to very, very basics on this, the placenta is the baby's life support system, correct?
Right.
Or-
The
okay.
placenta connects baby to you.
Okay.
So all of the transfer of nutrients goes through the placenta.
That's the arm up by the
Funny.
ear. You see the umbilical cord in the 3D picture right here. Right there.
Oh,
There's
okay.
the mouth.
Sure.
And kind of moving away from us.
Sorry, not the best 3D picture
Yeah.
because
Well,
your baby's being uncooperative.
I'll have a talk with it later.
Yeah. It's better.
Oh my gosh,
Look
that
at
is so
it.
crazy. Yeah, you're
That's
right.
baby
It just,
moving.
That's
That's not me.
wild. Oh, that is.
Is that right?
I want to say that looks incredibly creepy. I mean, it's beautiful.
Yeah, that's really cute.
Yeah. Looks great.
Anything else you want to look at?
I think we're good. If we haven't revealed anything, you haven't seen anything?
No.
Nope, nothing.
Awesome.
I
And
don't know
we're
what you're
gonna
having.
call you don't even know?
No, I don't know.
Fabulous.
Yeah.
All right, so we'll sit up, and I should look over. I can't see anybody. Do you have any questions coming in?
I don't have any questions. Lots of way cool, excited to see
Thanks.
this, but no specific
And as
questions.
I sit up, I'm reminded that at this point I have a terrible time sitting up straight and not wanting to just go right back down. I
Yeah.
guess that's pretty normal at
Totally
this
normal.
stage.
Totally normal.
All right. So let's talk about once the scan is done, we're gonna flip some lights on here in a second so we don't look quite as ominous. But once the scan is finished and you've got your pretty pictures to take home, if there is anything that needs to be addressed, how will you learn about that? I mean, does it vary from place to place, or what's the norm around here?
Yeah, for us, one of our attendings will come in and talk to you about what's going on. If we have any concerns, and if we have any other tests that we would recommend, or if we want to do another ultrasound, or sometimes we do MRIs of babies while they're inside still. Sometimes people need to talk to other kinds of physicians. But you'll hear right away. I mean, so after the scan is finished, if there's any concerns, you'll hear right then.
Oh, okay.
Oh,
That's really good to know. I was not 100% aware of that, I don't think, whenever mine was going on, and I could have been told. And I think that's the nice thing about this format, too, is it answers a lot of these questions before you're in that position, because when you're in it, it's exciting and it's nerve-wracking and all of that, and so you're not necessarily aware of everything
Yeah.
that the doctors are telling you.
Yeah.
So if the couple of other things let's talk about coming out of the appointment. I know we have a fetal care center and a fetal heart center, and all of these places that we see pregnant women who come from their appointments at Barnes Jewish right over to St. Louis Children's Hospital to check on baby. And so is it monitoring, or does it vary? I know it varies from person to person, but are there a lot of things that can be watched and anticipated before baby arrives?
Yeah, I mean, certainly, most things that we see on ultrasound, it's really most helpful just to get parents ready, for what might happen, after delivery. So to avoid any big surprises. There are a few things that we can treat while the baby's inside, but not all that many.
All right.
Does that answer your question?
Yes, it does. I think the biggest thing is just alerting people that there are a lot of the bad news is not necessarily dire news
Right.
at these appointments. That there is just so much, and we've seen a lot of babies who, if there is that hole in the heart, or if there is the hole in the diaphragm, that the care exists for them and the channels are set up so that they'll be cared for, both mom and baby and family structure entire, whatever it may be, throughout the course, and that their wishes are honored and they're prepared.
Yeah, totally.
They are.
I think that one of our main jobs is to give people information. And if there's something that it doesn't seem right on the ultrasound, it's always a shock, to parents, and is always upsetting, even if it's something that is probably going to be fine. And our job is to help you through that, and we help by, I think, giving a lot of information and like talking a lot and always being available for our patients. So that's something we try to do a good job of.
And I've learned along the way, I have yet to have any doctor roll his or her eyes at me or be annoyed by a question, and I have a lot of them, and a lot of them are just, like I said, you start talking about being dangerous, it's probably more annoying than dangerous, because it's the vocabulary is there, but the understanding is not. But you're there to translate everything and to make sure that everyone is making informed decisions.
Absolutely, that's our job.
All right, and if there's any advice that you have for women who are going into ultrasound, do you have any?
Enjoy it. It's a nice, it's a nice thing, and go to a great place. So you have somebody really good looking at the pictures, and somebody great like Kim getting the images, and get some good pictures.
All right, terrific, and thank you so much. Kim is back over in the corner now. I do have one final question, and that is, do you have to drink 2 full giant bottles of water right before you go in?
Not super full, but have a little bit in your bladder.
Have a little bit in your bladder.
Yeah.
All right, very solid advice. Well, thank you all so much for tuning in. A couple of other things to note. We had a lot of questions that came in for the high-risk specific episode last week with Dr. Ebony Carter, who works with you, and it was such a great hour that we spent chatting with her, and she brought up a number of resources. So we do have a question. So, but a number of resources that we didn't have the numbers off the top of our heads, and the websites right then. Those have been posted in the comment section of last week's episode. So if you need any of that information, it's there for you. And we do have another question.
Yeah, we just got one from Joycelyn, I think that's how you say her name, and she asks, are multiple ultrasounds bad for the baby?
Yeah, it's a great question.
It is a really good question, and one I meant to ask earlier.
Yeah, no, they're not. I think sort of the theoretical concern of ultrasound is that it can actually generate some heat, but with the machines that we use today, it's really not a concern at all. So there's really no safety concerns at all for ultrasound during pregnancy. There's no radiation, so 0 radiation with ultrasound. So it's not like a CAT scan or a chest X-ray or something like that. It's a different technology, like really 0 risk.
And that's something that's in contrast to what we talk about in the pediatric world very regularly, and I think in general, that you want to minimize your exposure to radiation. So those tests are things like CT scan and X-ray, and did you mention another one?
No, chest X-rays
Okay.
or some other.
And it's nice to go someplace where they are trained facilities, so that you have either someone who knows exactly how much radiation can be administered in the radiation involved test, not ultrasound. That we're talking about here, but we have at Children's, we have pediatric specific radiologists who know how to read scans that were done with less radiation, or to order an ultrasound instead of the CT, something like
Right.
CT.
That's actually
Ultrasound.
really important.
It is, yeah. Okay. All right, well, thank you so much for joining us. In a couple of weeks, we will be off next week, owing to a lot of folks traveling over the weekend. So we will be back in 2 weeks to talk about fetal hearts. So we'll take a look at baby's heart in closer detail then. Thanks so much for joining us. We'll talk to you later.